Good afternoon. My name is Heidi, and I will be your conference operator today. At this time, I would like to welcome everyone to the Antibiotic Stewardship National LAN event. All lines have been placed on mute to prevent any background noise. After the speaker's remarks, there will be a question and answer session. If you would like to ask a question during this time, simply press star, then the number 1 on your telephone keypad. If you would like to withdraw your question, press the pound key. Thank you. Kaylee Doyle, you may begin your conference.
Good afternoon, and thank you everyone for joining us for the first Antibiotic Stewardship National Learning and Action Network, or LAN event. We're happy to have you all with us today as we discuss the important topic of understanding physician-to-patient communication strategies to avoid unnecessary antibiotic prescribing. My name is Kaylee Doyle. I'm a program manager with Telegen and the Quality Innovation Network National Coordinating Center, or the QUIN-NCC. So I'd like to go over a few reminders and housekeeping items before we get started today. Thank you all for joining us in the WebEx Event Center. In order to get into the WebEx, you will need your registration confirmation email and a unique registration ID to log in. My colleague, Rachel Dignan from Telegen and the QUIN-NCC, will be monitoring our WebEx chat board today. So please be sure to participate as we go along, and feel free to ask your questions in chat. Slides and resources and the recording from today's session will be posted on the QIOprogram.org website under the Events tab. And this will be the fourth event from the top under that Events tab. Some of the resources for the call are already posted there on the QIOprogram.org website, and the remaining resources will be posted within the upcoming weeks. So let's start by going over what's the agenda for today's call. First, I'm going to go over the continuing education details. Then I will introduce each of our speakers today, Dr. Lori Hicks with the Centers for Disease Control and Prevention, and Dr. Rita Mangione-Smith with the University of Washington's Department of Pediatrics. There will be a facilitated discussion following Dr. Mangione-Smith's presentation, during which we will address questions posed in the chat and via the phone line. If we don't get to your questions right away, know that we are compiling those, and we will attempt to address as many as we can during the discussion portion of the call. And then finally, I'll wrap up with a reminder to complete our post-event assessment and a plug for upcoming calls. So let's get to the purpose of today's event. We will prepare healthcare quality improvement professionals to identify and implement effective communication strategies to avoid unnecessary antibiotic prescribing. We are hoping to make this webinar as interactive as possible, and this can be a challenge given such a large audience. So we want to ask you to commit as an individual to being attentive, active, and actionable, and think about all the ways the content is relevant to your work and priorities. We welcome your active participation by clicking the green check in the WebEx application as seen on the slide. To do so, you can click the conversation bubble, choose the yes in the drop-down menu. You can also type yes in chat to show your commitment to active participation today. Great, lots of yeses, thank you. Okay, so we're very excited to be offering continuing education credits to all attendees participating in today's event. We offer credit to all physicians, physician assistants, registered nurses, nurse practitioners, dietitians, pharmacists, and pharmacy technicians. We also offer credits of attendance, or certificates of attendance. Should you have requests for additional accreditation types, we welcome those suggestions as well. So please put those in chat, or you can post them in the post-event assessment. So in order to apply for the continuing education credit, you need to attend the entire event and complete the post-event assessment upon exiting the WebEx session. There's a separate evaluation required for the CE credits that's accessible through the post-event assessment. Once you submit your CE evaluation, you'll be provided with a certificate to retain for your records. For any technical assistance related to the CE process, please email Nikki Rosales, and Rachel will put her email in the chat box. So this slide shows a disclaimer from our partnering provider, CRW and Associates. This activity awards 1.5 AMA credit hours for physicians and physician assistants, and you can reference the slide for the full CE statement. This activity also awards 1.5 contact hours for nurses and 1.5 continuing professional education units for dietitians. This slide provides the accreditation statements for those entities. So here's another disclaimer. We'd like to report that the planners and faculty for this event, CRW and Associates, Intelligence, do not have any financial relationships to disclose, nor was any commercial support received for this activity. And here are the disclosures of financial relationships. So just as a reminder, you must participate in the entire live activity to claim the continuing education credit. Okay, and now we'd like to get an idea of what types of organizations are joining us today on the call. So we invite you to respond to a poll to indicate where you are working. So Jennifer, can you please pull up the poll? I can see some people are already typing in chat. Thank you. We'll wait just a minute for Jennifer to pull that up. Great, thanks everybody for participating in chat. Jennifer, can you pull up the polling question? Okay, we might be having trouble, but I can see lots of different organizations, hospitals, nursing homes, SNFs. Great to see all of you here in chat. Thank you all for joining today. So I will now go over the objectives for today's call. So by the end of today's call, you should be able to explain why providers are prescribing antibiotics inappropriately, discuss why communications training is a good option to improve outpatient antibiotic prescribing, learn how patients most commonly communicate their expectations for antibiotics, and gain an understanding of how to best manage expectations for antibiotics in order to avoid unnecessary prescribing while maintaining satisfaction with care. It's now my pleasure to introduce our first speaker from the Centers of Disease Control and Prevention. Dr. Lori Hicks is a medical epidemiologist in the Division of Healthcare Quality Promotion at the CDC. She's also a captain in the U.S. Public Health Service. In 2008, Dr. Hicks became the medical director for the Get Smart Know When Antibiotics Work program, which aims to educate healthcare providers and the public about appropriate antibiotic use. She leads research on antibiotic use and resistance trends and serves as the campaign spokesperson. Globally, she has fostered CDC, European Union, and the World Health Organization collaboration, leading to joint antibiotic awareness observances. In 2015, she became the director for CDC's Office of Antibiotic Stewardship in the Division of Healthcare Quality Promotion to improve integration of stewardship across the healthcare continuum. Dr. Hicks, thanks for being with us today. The floor is yours.
So I really appreciate that introduction, Kelly, and it is my honor and privilege to speak to all of you and provide a prelude to Dr. Rita Mangione-Smith's presentation. And my background is in adult infectious diseases, so improving how we use antibiotics has been near and dear to my heart for many years. So I hope that we can convince you that communications training is a key to improving how we can use antibiotics and improve prescribing. So while outpatient antibiotic prescribing has improved, a significant proportion of outpatient antibiotic prescriptions are still inappropriate. So just for starters, over 260 million outpatient antibiotic prescriptions are filled each year in outpatient pharmacies. And if you just kind of try to apply that to the U.S. population, that's enough for every 5 out of 6 Americans to get a prescription each year. And we know that a significant proportion of those prescriptions are unnecessary. So I have the figure on the right-hand side of the slide, so take a look at that, and you will see results from a study that was led by Dr. Catherine Fleming-Dutra on our team. And we found that in doctors' offices and emergency departments, 30% of prescriptions were completely unnecessary, and that equates to about 47 million unnecessary prescriptions just in those settings. That does not include retail clinics and urgent care settings and post-hospital discharge prescriptions. While we have seen improvements in prescribing, this has been solely driven by reductions in prescribing for children. Very little to no improvement has been seen among adults. 40% of adults with upper respiratory infections, which I presume to be caused by viruses, are prescribed antibiotics. And for more than 20 years, over 70% of adults have received antibiotic treatment for acute uncomplicated bronchitis, which doesn't warrant antibiotic treatment at all. And even when antibiotics are indicated, first-line antibiotics are only prescribed in about 52% of cases for the most common diagnoses leading to antibiotics: otitis media, sinusitis, and pharyngitis. So there's a lot of opportunity to improve how we select our antibiotics. And the most common drugs like macrolides and fluoroquinolones and we know that there are several reasons why providers prescribe antibiotics inappropriately, and it is not, and I'm underscoring not, generally driven by a knowledge deficit. It's not a knowledge problem. In fact, most prescribers are familiar with clinical guidelines for treatment of infections, and we hear this over and over again when we do our formative research with providers. The reasons for inappropriate prescribing include habits. Certainly changing deeply embedded practices is hard. Diagnostic uncertainty and concerns for bacterial complications is a common reason that we hear from physicians or other providers that they prescribe. Conditions like sinusitis, where they're uncertain about the seriousness of the infection. However, the reasons that are almost universally cited by clinicians include patient or parent pressure and satisfaction. Clinicians commonly perceive that an antibiotic is the most common reason for the clinic visit, and clinicians cite fear of losing patients to other providers or being subjected to a bad review. And we're hearing more and more about how providers are really concerned about the reviews that they're getting online and how that it may actually have an impact on their reviews with their employer. So this is something that has been a concern that's been raised pretty consistently. What we have learned from studies that have looked at these issues is that patients do not expect antibiotics as often as we think they do. Although I am a physician as well, I have certainly experienced this, and I have had patients and even family members and friends come and ask me for antibiotics. But we have learned from qualitative studies that clinicians were actually found to overestimate the actual pressure to prescribe antibiotics. We know that clinicians are much more likely to prescribe antibiotics when they think the patient or parent wants them. And the doctor's perception of the patient expectations were found to be the strongest determinant of medication prescribing. So again, this is really the major driver. But I think it's important to remember that miscommunication is really a two-way street. And while clinicians may misinterpret patients' expectations, we may also overestimate the frequency of our patients understanding what we're communicating to them. And a number of studies across different settings have demonstrated that patients frequently misunderstand their clinical condition or the instructions they receive from healthcare providers. Examples provided here show poor patient recall for potential risks and complications of procedures after informed consent, ranging from 21% to 86% of patients were able to recall potential risks and complications of their procedures after informed consent. And in another study, just under 80% of patients demonstrated a comprehension deficit of the care and discharge instructions from the ER, and 80% weren't really confident in their comprehension and recall. So clearly, this is a problem. Most clinicians have developed effective communication methods. However, with time limitations and clinic visits, communications training on the specific topic of antibiotic use helps to reduce unnecessary prescribing. The goal of communications training is to facilitate patient and clinician communication while addressing the patient's expectations for receiving an antibiotic. And while Dr. Mangiani-Smith's work has focused a lot on kids, communications training is not just for pediatric providers. And I have a number of studies on the slide here that show that some of the studies have looked at this question in adults. In fact, many of them have been conducted in the UK or in Europe. In a review of outpatient stewardship interventions, communication skills training was found to significantly reduce antibiotic prescribing. And the third bullet on this slide provides details about a study that looked at two stewardship interventions. One relied on a CRP or C-reactive protein test to guide decisions. This group prescribed antibiotics to 31% of patients compared with 53% in the no-test group. General practitioners trained in enhanced communication skills prescribed antibiotics to 27% of patients with respiratory infections compared with 54% in the no training group, so an even greater spread with that lower cost intervention. And the last bullet on the slide highlights a study by Little and colleagues that was published in Lancet, also looked at C-reactive protein and communications training and found them both to be effective. It is my opinion that good communication is the foundation of good antibiotic stewardship. Communications training is a good investment for a number of reasons. Minimal time and resources are required, and I expect that there will be more easily accessible online training resources on this topic in the near future. We're working on some of them. There are good data to suggest that the effect of communications training is sustained over time, contrary to some other interventions. And the reason why it's so effective is that it gets at the core of the problem, which is really about patient comprehension, expectations, and satisfaction. An added bonus is that it may even improve clinician satisfaction, because when patients' communication needs are met, this reinforces the clinician-patient relationship. So lastly, I want to point out that the CDC's core elements about patient antibiotic stewardship, you will find that communications and communications training are prominently featured in this document. If you have limited resources in your clinic to implement stewardship and want to work on meeting the core elements, know that this is one of the more effective actions you can take. And you can see this mentioned in the section under the Actions or Policy and Practice core element. You will also see it mentioned under the Education and Expertise core element. So yes, we're a bit obsessed with this concept. I hope this helps you understand why we think communication training is so important. And I'm going to just mention that some people have celebrity crushes, but mine tend to be more scientific crushes. And now I would like to turn you over to someone who I consider one of the leaders in the field, Dr. Rita Mangiani-Smith. who has quite literally changed the clinician and patient conversation around antibiotic use. So I'm going to hand it back over to Kaylee, and thank you for that opportunity to provide the introduction.
Thank you so much, Dr. Hicks. And as Dr. Hicks has just done a great introduction, it's now my pleasure to introduce you to our next speaker. Dr. Rita Mangione-Smith is a professor-in-chief with the Division of General Pediatrics and Hospital Medicine for the University of Washington Department of Pediatrics. Dr. Mangione-Smith is also a senior investigator for the Center for Child Health, Behavior, and Development at the Seattle Children's Research Institute and an adjunct professor of health services at the University of Washington School of Public Health. Through her research program, she designs and conducts studies that facilitate assessment of healthcare quality, as well as the development and testing of interventions aimed at improving pediatric care. So Dr. Mangione-Smith, we appreciate you for being on today, and the floor is yours.
Thank you so much, Kaylee. I have not been past the ball yet. There it is. Okay, great. Bear with me for just one moment. I'm going to screen share for my part of the presentation. And there we go. Great. All right. So, first of all, thank you for those incredibly gracious introductions. I hope that the presentation can live up to the introduction. It gives me a lot of pleasure to have this opportunity to talk to you about optimizing communication with parents during pediatric visits for acute respiratory tract infections. I know many of you are adult healthcare providers, and although these and much of what I'm going to talk about has been studied in the pediatric population, I do believe much of it translates to the adult population for the simple fact that myself as a pediatrician, I mostly am dealing with adults in that I'm mostly dealing with communicating with parents. So those of you who take care of frail elderly patients, who have caregivers who bring them in, I will be able to relate to that triadic kind of communication that has to go on. And I think this also, as I said, will apply pretty well to the adult population. So I have no relevant financial relationships or conflicts of interest to disclose. So first, I want to go over our presentation outline. So first, I'm going to briefly review what we've learned about provider-parent communication during visits for acute respiratory infection. Second, I'll show you some video examples that will emphasize some of the key points about effective ways to communicate during these visits. And then finally, we're going to certainly have some time at the end for questions and answers. So today, what I'll share with you from our prior research findings is based on what we've learned over the past decade by carefully analyzing over 500 videotapes of actual office visits for pediatric acute respiratory infection. By doing so, we've learned which communication practices work best to increase satisfaction with care, decrease unnecessary antibiotic prescribing, and importantly, shorten visit lengths. So some of our key findings include, first, the way parents communicate during visits for their child's acute respiratory infection strongly influences whether we perceive them as wanting antibiotics for their child. Secondly, as Lori mentioned, when we perceive that parents want antibiotics, you're significantly more likely to prescribe even when the illness is most likely viral. The good news is that there are effective communication techniques that we can use to successfully manage this perceived pressure to prescribe and at the same time maintain satisfaction with care. So why is this so important? Similar to what Lori was telling you about, these are some of the pediatric data. We know that an estimated 32 million pediatric visits for respiratory conditions result in antibiotic prescriptions annually, accounting for greater than 70% of outpatient visits where antibiotics are prescribed to children. And given that less than a third of these infections in children are estimated to be caused by bacteria, current prescribing patterns almost certainly are excessive for these infections. In fact, this discrepancy represents an estimated 11 million potentially preventable antibiotic prescriptions annually. So what does our prior research tell us? Well, what we learned is that many parents expect antibiotics for their child's respiratory infection. However, they rarely directly ask for them. Managing those expectations to avoid unwarranted prescribing is certainly important. We also know that parents commonly use indirect communication practices that lead us to think that they expect antibiotics. And we know that perceiving that a child's parent expects to receive antibiotics is a key driver of unwarranted prescribing. So it's really important to understand what parent communication practices drive us to perceive them as wanting antibiotics. So next, I'm going to review results from an analysis of our study videotape data, where we asked the question, how do parents indirectly communicate their expectations for antibiotics? So parent expectations for antibiotics affect how they communicate during visits. One place where parents indirectly communicate their expectations for antibiotics is during the presentation of their child's problem. And one type of problem presentation a parent may use when they expect antibiotics is offering what we call a candidate diagnosis. The candidate diagnosis can be explicit, where the parent actually names a potential diagnosis. For example, I'm really worried that she might be coming down with bronchitis. Or implicit, the parent describes symptoms in a way that implies a particular diagnosis. For example, the stuff coming out of her nose just won't quit and it's getting really thick and green. Or the parent can assert that someone else in the family or at school has been diagnosed with a sinus infection or has strep throat. For example, I've heard that a bunch of kids in this class have been out sick with strep. So when a parent presents their child's problem using a candidate diagnosis, they are 25% more likely to have come into that visit expecting antibiotics for their child. Whether or not a parent offers a candidate diagnosis in their problem presentation, there are communication practices that you can use to successfully manage those expectations for unwarranted antibiotics. Making the case for your diagnosis is important, and how treatment recommendations are structured is key. Now I'm going to review the 4 key communication practices you can use to successfully manage parent expectations for antibiotics. We'll start with the first 2. The first is reviewing your physical examination findings, and 2, delivering a clear diagnosis. When you perceive parents as expecting antibiotics for their child, you can decrease unwarranted prescribing by first reviewing your physical examination findings. For example, his ears look good and his lungs sound great, so no ear infection or signs of pneumonia. His nose is pretty congested though and his throat is a little red, but nothing concerning for strep. And second, delivering a clear diagnosis. For example, so what we have here is a really bad cold. Now we'll review the 3rd key communication practice for managing parent expectations for antibiotics, which is using a 2-part negative-positive treatment recommendation. So there are 2 main ways that we as providers tend to make treatment recommendations during visits for acute respiratory infection. Negative treatment recommendations that rule out the need for antibiotics. For example, this is just a cold, nothing an antibiotic will touch. And positive treatment recommendations for symptom relief. For example, raising the head of her bed will help with the drainage from her nose when she's sleeping, so she won't cough so much. Research shows that parents generally expect to get advice on how their child's symptoms can be treated. And they're quite frustrated when we only recommend that no treatment is needed. We also know that negative treatment recommendations, when given alone, can increase parent questioning of the treatment plan. which then shifts provider decision-making into provider-parent negotiation and increases the probability of unwarranted prescribing. Parent questioning also extends the visit length by forcing us to re-explain why antibiotics are not needed. So in recent work, we looked at how the use of positive and negative treatment recommendations for viral acute respiratory infections is associated with prescribing and patient care ratings for these visits. The findings are pretty straightforward. When combined, a negative treatment recommendation followed by a positive one had the lowest association with unwarranted prescribing, the strongest association with higher parent visit satisfaction ratings, and led to shorter visit lengths. What I consider a win-win outcome. So how you structure your treatment recommendation is key, and I'm going to be reviewing this in the video examples I present to you today. So the tendency for parents to question the treatment plan is more likely to happen in two cases. When the provider only presents a negative treatment recommendation, or when the provider starts with a positive recommendation and ends with a negative recommendation. This means that how you lay out your overall treatment recommendation is really important. We recommend always leading with a negative and ending with a positive treatment recommendation. It's important not to provide an open space for parents to respond to the negative part of your treatment recommendation. So how can you prevent this from happening? What we found by looking at so many video examples from actual visits is that by using the following structure, you can avoid having this happen. Start with, on the one hand, antibiotics won't help him get better, the negative treatment recommendation, followed by, on the other hand, there are lots of things you can do to help with his symptoms, like giving him a teaspoon of honey before bedtime to help with the cough and running a humidifier in his bedroom at night to help break up the congestion, the positive recommendation. Using this on the one hand, on the other hand structure, or alternatively you can say there's bad news and good news. That's another way to structure it. This lets parents know you aren't done speaking after presenting the negative recommendation, which decreases the likelihood that they will interrupt and respond to it by questioning your treatment plan. Now we'll review the fourth and final key communication practice for managing parent expectations for antibiotics, which is providing a contingency plan. So, prior research shows that parents are more satisfied with their child's visit when the provider outlines a contingency plan. So what is a contingency plan? It basically involves indicating that if the child you're seeing doesn't improve in the next day or two, the parent should recontact you and the treatment plan may change. And that recontact can be via telephone or return visit. Here's an example of a contingency plan. Definitely call me if she starts having high fevers or is having a hard time catching her breath. I don't expect that to happen, but that's what you should watch for. So basically, a contingency plan is leaving the door open for future contact. When you don't prescribe antibiotics, giving a contingency plan can increase satisfaction with care for parents who expected to receive them. Let me orient you to this graph. Here on the y-axis, from this study, we have satisfaction scores going from a score of 0, which is the worst possible visit, all the way up to 100, which is the best possible visit. Here, down here, we have whether or not, on the x-axis, you received a contingency plan, yes or no. So in this study, all of the parents represented on this graph are parents who came in and on a pre-visit survey told us they expected to receive antibiotics. However, they didn't. For those who expected antibiotics and didn't receive them, if they received a contingency plan, so contingency plan is yes, from their child's provider, their satisfaction on that 0 to 100 scale on average was 76. In contrast, if they came in expecting an antibiotic, didn't get one, and they also did not receive a contingency plan, their satisfaction level was only 59. So when you don't provide expected antibiotics, giving a contingency plan can go a long way. For you to know my email address. I know there are many, many of you on the phone, and if you don't have a chance to ask your question and you would like to contact me, this is my email address, ritams@uw.edu. I will also be providing this list of references to the coordinators of this LAN call. So that if any of you are interested in reading some of the studies that led to the recommendations that I went over in this particular presentation, you can do some more reading. Okay, and I will stop sharing at this time, and I will give the ball back to Kaylee, correct?
Yes, thank you so much, Dr. Mangione-Smith. Great presentation. We had such great feedback in chat. I'm excited for this discussion portion of the call today. So at this time, Dr. Hicks and Dr. Mangione-Smith are available for questions and comments pertaining to the presentation. So Heidi, can you let participants know how they can call into the phone queue?
Certainly. As a reminder, in order to ask a question, just press star, then the number 1 on your telephone keypad. And we'll pause for a brief moment to compile the Q&A roster.
Okay, and while you're doing that, I'll turn it over to Rachel Dignan to see if there's anything you'd like to highlight in chat, any conversation or questions.
Hi, Kaylee. Yes. Can you hear me?
Yep.
Great. There were a few references in chat to the phone clinic, telephone, telehealth visits that people are having, and perhaps antibiotic prescribing that is occurring without seeing the patient in person. And just wondering if Lori or Rita have any comments or thoughts about management or ways to approach that particular issue.
Lori, do you want to take that one?
Sure. So this is Lori, and I would say that it's a really, really important question, and one we're still trying to understand. What are the steps, and how can we incorporate stewardship into the telemedicine model? And I would just say that, first of all, we don't have any data on how antibiotics are being prescribed using the telemedicine model. We're hoping that we can partner with some organizations to better understand how antibiotics are being prescribed, and we recognize that there are some situations where the patient may not necessarily be examined at all, and so I think we certainly have some concerns about how you would make a distinction between a bacterial and viral illness when the patient isn't being examined. Having said that, I think there's still probably opportunities to have these kinds of conversations, even if it's over the phone or via some sort of electronic interface in terms of what you might be saying to a patient if they're able to describe their symptoms to you, and if they sound like a viral respiratory illness. I think you would probably take a very similar approach to what Rita recommended in terms of it sounds like you have a nasty cold, and start off with some positive recommendations for what can be done rather than prescribe antibiotics. So I have to say, I think we have some work to do in this area, both at the national level to understand what kind of practices are being used in this particular setting. And then, once we know more about that, then I think we'll have to look into what are the opportunities to improve use. I'm going to turn it over to Rita from there.
Yeah, and I think many of the communication strategies that I just went over, obviously other than being able to make the case for your diagnosis by going over physical examination findings, you could at least, I think, substitute in for that symptoms you're hearing that are not consistent with a bacterial process or that are consistent with a viral cold. So summarizing symptoms that would make the case for a viral diagnosis. Again, being very clear, this sounds like it's a really bad cold. There's a lot of that going around. So, this type of illness is, on the one hand, this type of illness is something that antibiotics isn't going to help. But on the other hand, I can make a lot of recommendations to you about, how you can potentially deal with some of the symptoms that you're having. And here are the things that I think would trigger a need to be seen. So I think that we could certainly train to those types of visits, and I can't emphasize enough the importance of what Lori said about really getting a better understanding of how prolific or not antibiotic prescribing is using telehealth, because I do think it's going to only increase.
Perfect. Thank you. I do have one other question, Kaylee, if that's okay. Sure, one more and then we'll go to the phone line. Okay, this is a question for Rita. We understand that your videos are not yet published and are pending publication. We're just wondering if you estimate when the videos would be made available.
Yeah, so we actually are in the process of doing a study where the videos are included as part of an intervention to see whether or not we can change prescribing with some of the webinar content you just saw in addition to other aspects to the intervention. Our last group of physicians to go through the intervention will finish it in early September, so we should be able to post the videos for public use, I would say maybe by October 1st.
Perfect. Thank you so much. Kaylee, I'll turn it back over to you to check the phones.
Okay, thanks. Heidi, do we have anybody in the phone queue?
Yes, we have a few. Your first question comes from the line of Adrienne, and please go ahead.
Thank you very much. I am happy to be able to be on the call today, and I think that some of the recommendations that you provided are helpful even in the management of adult patients, specifically validating that they are sick. You are sick, especially when they're taking time off from work and came in. They really want to be validated that they are sick. And I agree with the part about telling the patient about the things that they can do. And as I've been giving this presentation, very similar to this, to many physician audiences, they always talk about the patient who, for so many years, has always come in with early symptoms of a sinus infection or a URI and insist that they always need antibiotics. And so the practice that is also on the CDC website of writing a prescription and telling them, hold this and don't fill it until a later date. Can you speak a little bit about that also? Thank you.
So I think that that's a really great alternative way to handle the exact scenario that you are presenting. We don't see it so much with sinusitis in pediatrics, but boy, we see it often with acute otitis media or ear infections, where, the parent will be like, this is always how he is just before he gets a really bad ear infection. So, even though you're not seeing anything terrible right now, I just really know we're going to need the antibiotic. And in those situations, using what, and we call those contingency prescriptions, right, where you give a prescription, but you kind of give them the contingency plan with the prescription saying, I'm going to give you this prescription. I really, really don't think you need to start it, and here are the parameters I would want you to meet before you do start it. And many times we also, when we're doing our pediatric resident training around this, we'll tell them if you're going to do a contingency prescription, ask that the parent, call in and try to talk to you or, page you, just to have a conversation before they decide to start, if at all possible, to make sure that you're on the same page that the child should be started. So I think that is a very reasonable alternative approach when you have somebody who has been treated over and over again, whether appropriately or not, to try to prevent that actual prescription from being filled. At least in pediatrics, there are clearly studies that have shown that those contingency prescriptions are only filled about 35% of the time. So the other 65% you prevent it. So I think that's a meaningful amount of prevention.
And this is Lori. Just one additional comment, and I absolutely agree with Rita, is that one thing we recommend as well, if you can do this, to put, I know it may be difficult without an e-prescription, but if you can do it, put an expiration date or some sort of notation. The prescription should expire after a certain date, because we also don't want patients saving these or filling these months out for something else. And the other recommendation or general guidance we provide is that these contingency prescriptions, or what we sometimes call delayed prescriptions, should only be prescribed for situations where there is that diagnostic uncertainty around, particularly around sinusitis and acute otitis media, when you really think it is a viral upper respiratory infection. We don't want to send the wrong message that an antibiotic might be warranted for that particular case. So I would say in the situations where there is diagnostic uncertainty, it is truly reasonable to take that approach.
Great, thanks, Dr. Riggs and Dr. Mangione-Smith. Heidi, is there another question in queue?
Yes, we have a question from someone whose information was not recorded. If you're queued up, please go ahead. Your line is open. If you're queued up, please unmute your line and go ahead. Your line is open. Okay, your next question comes from the line of Paula Roy. Please go ahead.
Hi. I appreciate taking my question. I work in urgent care, and the contingency plan, I think it's great, but it's a little bit difficult because we don't do follow-up. We try to refer them back to their primary care provider within a couple of days. But so I think, I just had a question as what you would do with the, urgent care setting more. And, the other issue that we have is we don't have that established patient rapport because we're not their primary provider. So there's a little bit higher risk, I think, in our setting as well. So could you address those issues, please?
Yes, absolutely. So I'll take the first one first, the contingency plan issue. I think in the urgent care setting, it would obviously have to shift to giving the clear parameters for calling their primary care provider or visiting their primary care provider, or alternatively, if they're in urgent care because they don't have a primary care provider, which is sometimes the case for us in pediatrics, letting them know what should bring them back into care. Again, giving very clear parameters about symptoms or signs that would be concerning enough to present to care again, whether it be back at your urgent care or with the primary care provider that they hopefully have. In terms of the longevity of the relationship, in many of our studies we looked at whether or not the family was seeing their child's primary care provider and for how long they had been going to that primary care provider with their child. And what we found in all of our analyses, and I find this kind of reassuring for people in urgent care, it didn't matter whether people were seeing a provider for the first time or whether they had a long-standing established relationship or a medium-standing relationship with them. It really did not alter the findings around what I've presented to you today. So they really apply whether it's, a patient who has been in your practice for, 10 years, 5 years, 1 year, or somebody you're seeing for the very first time. And frequently, even in the primary care outpatient setting, when a patient or a parent calls in for an acute care visit, many times they can't get in with their primary care provider that same day. So oftentimes, even if we're not in an urgent care setting, we are seeing patients that may not be our own.
Great, thank you. We'll go back to Rachel to see if there's additional questions in chat.
Hi, Kaylee. Yeah, there were several references in the chat for the presenters to talk about recommendations in applying these principles or techniques in the long-term care. setting or acute inpatient setting. So just wanted to see if Lori or Rita could talk a little bit about that.
So this is Lori. I'm happy to speak about this with respect to the long-term care setting. I think that's a situation where there's a lot of interaction potentially with a parent, with the parent's children, and in that scenario, it may actually be quite similar in terms of that triad, which Rita mentioned earlier, in terms of the interaction between the healthcare professionals in the facility, the patient themselves, and then of course the family member or members. And so one thing that we've been talking about here is that we're hoping to encourage more dialogue between the patient's family members and the providers and the healthcare staff at nursing homes to have a more open conversation about antibiotics, and the discussion may actually be a little bit different, because sometimes the antibiotic is prescribed and the patient or the parent may not even realize that they're on an antibiotic. And so we actually are encouraging those family members to say, oh, I heard that my mother is on an antibiotic. Can you explain to me why she's on an antibiotic? So that it's a little bit, there's that piece of the conversation that may be quite a bit different than the, oh, I think my mom has a respiratory infection. Doesn't she need an antibiotic? But that also does happen in nursing homes as well, and we hear that it's often the patient's family member that expresses concerns to the staff. And it also is often the patient's family members that notice a change in mental status. And that change in mental status may automatically trigger the requisite urinalysis, which often is positive regardless of whether the patient has a urinary tract infection or not. So what we're encouraging is really having more of a conversation. The conversation we're encouraging the patients to initiate that conversation, the patient's family members to initiate that conversation, and also the healthcare providers to kind of understand what are the different dynamics in this setting. It's a little bit more challenging because obviously it's a more complex patient population. And it's not only about, okay, not giving an antibiotic, but when a patient gets an antibiotic, making sure that it's for the right reasons. So I think there's some principles of the outpatient setting that can be applied to the nursing home setting. I think it's a little bit more difficult when you start talking about the hospital setting. In the hospital setting, it's very unusual for someone to say, I want my vancomycin, whereas in the outpatient setting, you will often have a patient come in and say, well, I actually get a Z-Pak for this particular illness. Can you prescribe the same antibiotics for this illness? So it is a little bit different from that standpoint, and I will stop there and let Rita weigh in.
Yeah, I think certainly I can't really weigh in very much on the long-term care setting. However, on the inpatient side, for us in pediatrics, I think the interventions that we need to do around stewardship are somewhat different because it is much more provider-driven in the inpatient setting in terms of there isn't that either actual or perceived demand on the inpatient side, at least for us in pediatrics, as there can be in the outpatient setting. So I think while stewardship is absolutely a big issue on the inpatient side of things, I think the interventions have to be probably different.
Great, thank you both. And Rachel, any additional questions?
Yes, there are several. So this question is about identifying problem prescribers. There's a request to see if you have any recommendations on how to target specific prescribers that might need more guidance and training. So if you can share any information or tactics around that, that would be great.
So we're hoping that the overall intervention I was referencing earlier in the call is called DART. That was the beginning slide that you saw, dialogue around respiratory illness treatment. The DART intervention, the webinar content that I shared with you today is just one aspect of a multifaceted intervention that we're hoping is effective, and if it is, it will ultimately be offered as a way to do maintenance of certification. So we're hoping that that will be a carrot to get people engaged. We definitely have some in our study, some extreme prescribers, both on both ends, people who almost never prescribe and then people who are clearly doing some inappropriate prescribing. And I think for them, I think one of the pieces we're seeing that's very important is the fact that this is a multifaceted approach where we actually provide feedback reports to them on their prescribing patterns compared to both other practitioners in their setting and compared to everybody else who's in the study. And I think it's sort of that getting to see sort of that, wow, I'm kind of an outlier, you know, and I'm prescribing for pharyngitis, 70% of the time, where on average in the group it's at 40 and where the goal is really more around 30. That's actually helpful in raising that awareness. And we're finding, at least in our current work, that with implementing the intervention at the practice level and feeding back information to the entire practice, that way and we're taking advantage of peer pressure, basically, to say you are an outlier, and you may want to be especially engaging in this intervention to come up with techniques for maybe not prescribing as often as you are. So we're providing education around the guidelines and appropriate prescribing for respiratory infections. We're providing the information about how to change the way you communicate, and then we're doing these feedback reports to really try to use this multifaceted approach. So my hope is that these kinds of programs that we're developing and testing will become more broadly available to practices and other organizations that really want to address stewardship, particularly among their physicians where they're seeing inordinately high prescribing rates.
Thank you, Dr. Bandoni-Smith. So I'll check back into the phone queue to see if anybody's waiting there to ask a question.
Yes, we have a few questions. Your first one is from the line of Marlene Katz. Please go ahead. Marlene Katz, please unmute your line and go ahead.
Hi, taking the question. So, really appreciate the work that you're doing, and in primary care, we need you desperately. Just how you deal with after said and done, and you've done your good communication tendency, and the patient there. What I have gone sicker to get an antibiotic, or the person who says, look, I just took little Johnny's getting, yesterday to the urgent care, they were twice as sick, or they call your partner in 4 hours on call and give all those contingencies. How do you deal with that really hard person that you're just not going to win with?
So those are, first I want to apologize. You were breaking up a little bit, but I think what you were asking is, you can do all the communicate the right way, do everything that we're saying, but still have the parent who is actively really pushing to get an antibiotic. Our experience with the work that we've done is those, at least in pediatric encounters, while those parents really stick in your mind because they are very frustrating, they tend to be a very small percentage of who we deal with. And I think the inappropriate to suggest that you're going to be able to convince parents who come in feeling that strongly about it without them leaving dissatisfied if they don't at least get a contingency prescription. So I think, once you've sort of tried everything, I think it's just then a question of, your own comfort with your own practice. Are you going to kind of remain firm and not give the prescription and sort of know that, yes, they may call your partner on call or they may show up at an urgent care because they're frustrated that they didn't get the antibiotic from you. Or, do you want to take a middle-of-the-road approach and do the contingency prescription, knowing full well that that's the type of parent that's going to go fill it. I think that there are going to be a small minority of cases. I'd say we only heard direct requests for antibiotics of the over 500 actual visits that we videotaped. We only had direct requests in less than 5% of them. So, and I have a feeling it could be different in the adult world. I can't really speak to that, but at least in the pediatric world, those parents who are that aggressive are pretty rare. That I think then it really just boils down to what you're comfortable doing as a provider, and with the risk that you are going to end up with somebody who's dissatisfied if they don't get the antibiotic.
Great, thank you.
Your next question comes from the line of Claire Esselmayer. Please go ahead.
Thank you very much. Thank you, Doctor, for an excellent presentation. I started working in healthcare 40 years ago for pediatricians, so I just love pediatricians. And I actually took my 3 daughters to the pediatricians I worked for. And at that time, for strep throat, they would give you like maybe 2 days worth of antibiotics and then give you a prescription that you would fill out if the strep culture came up positive. So I always thought pediatricians are very good at antibiotic stewardship. My question to you is, how do you deal with parents with infants, especially new parents, and they come in and they, really the baby's sick and they really feel that the baby needs an antibiotic, or how do you deal with that?
So to be honest with you, in very much the same way that I presented, although I may spend an especially long amount of time going over what I found on physical exam and trying to be quite reassuring that, here are the things that I would look for that would really make me concerned. I'm not seeing any of those things. Here are the things that I am seeing that are very reassuring. Obviously things can change, and I definitely want to, hear back from you if that happens. But I would use the same kind of formatting of the treatment recommendation, but probably spending a little bit more time on that front end, really trying to walk them through what I was looking at with the exam, what I found and what I didn't find. Because I think most of the time you can bring that anxiety level down just by sitting down and going through that with them and answering questions that come up during that phase of the visit. So that would be my recommendation. It's not very different. It's just probably putting a little bit more investment up front to help them feel that you were thorough, you really checked things out carefully, and you're going to explain to them exactly what you did and didn't find and why that would support the diagnosis that you're going to make. So that would be my recommendation for that.
Thank you.
And your next question comes from a line that has yet to be transcribed. If you're queued up, please state your name and your question. Your line is open. If you're queued up, please unmute your line and go ahead.
Hi, my name is Amber Summers, and I work in long-term care. And my question was in regards to long-term antibiotic use. And I just wanted to know what you thought about how physicians prescribe prophylactic antibiotics to be given in in residents who have chronic urinary tract infections or maybe even chronic upper respiratory issues.
Lori, do you want to take that one?
Sure. So I think it's a really, what we're learning is that the prophylaxis issue is a common concern with respect to antibiotic overuse in the nursing home setting. And I think the problem is there's just not a lot of data to demonstrate, one, the benefits and the downsides of the long-term antibiotic use. But we certainly know that long-term antibiotic use has downsides, mainly that the patient probably, when they do develop a serious infection, will not be, that antibiotic will probably be ineffective for them if they've been on it long-term. And the data that I've seen has shown that actually a lot of times this prophylactic antibiotic use actually does not really do very much to prevent recurrences of urinary tract infections and particularly respiratory infections. So generally, I think it depends upon the patient and their underlying illnesses, but in the vast majority of patients, it's probably not a good idea. But that's a very much of a clinical decision that has to be made by the provider at that facility who knows that patient. But yes, I think that's probably a place where there is a lot of opportunity to improve how antibiotics are being used in nursing homes, is really carefully looking at those long-term courses and those prophylactic courses. One thing that we recommend for any antibiotic course is that you do a reassessment. Whether it's in a hospital setting or in a nursing home setting, you do a reassessment of that antibiotic course after it's prescribed, initially after 48 or 72 hours. And that reassessment should continue to occur. And so it really should not be a situation where a patient is placed indefinitely on long-term antibiotics. And I just would like to make one other comment. I mentioned someone asked earlier about communication around in the nursing home setting and acute care. And one thing I should have mentioned is that in the emergency room in the acute care setting, that is certainly a place where a lot of these communication techniques can be used. In the vast majority of cases, those are ambulatory patients. So I just wanted to make that point, that in that particular setting, these techniques can be employed. Thank you.
And your next question comes from the line of April Frego. Please go ahead.
You had mentioned some reports that you use to compare your providers and kind of incentivize them. I work in QI, and I'm really interested in what your output on those reports are. We've tried to look at those, and I can pull a list of patients by who received antibiotics, but then it's a manual process to go in and look and see, was this a good antibiotic prescription or not. So I'm curious as to your targets on the reports and what you're looking at.
Yeah, so thanks for that question. So one return question I'd have for you is, are you working with electronic health records?
Yes.
Okay, so in the current project that I was referencing, the DART project, part of the requirement to be in as part of the study was that your practice had to be on an electronic health record, and they had to also be putting data into a shared data warehouse with other practices who are in this research network. So all of the specifications for the prescribing reports that we generate come from data that we can abstract from electronic health record data. And we do have, they're not all on Epic or all on Cerner. We have people from several different vendors for electronic health records. So would be, when we're done, would be happy to share with you the specifications that we used in terms of lab tests, ICD-10 codes, and other things that we use to create the metrics that we share with the providers. So it shouldn't, and they're all run by a query, so there shouldn't be manual. Somebody would have to run the query and generate the report, but it's pretty what we've set up is pretty automated as long as you have access to the electronic health record data.
Okay, thank you.
Sure.
And we have another question from a line that has not been transcribed. Caller, if you're queued up, please unmute your line, state your name, and proceed with your question. Your line is open. If you're queued up, please unmute your line and go ahead.
Hello?
Hi, we can hear you.
Okay. Our question is in regard to our medical director. He's an older gentleman, probably in his mid-70s, and expressed to us even yesterday that, as a child, he remembers penicillin being widely used because it was a life-saving drug, and he genuinely believes that starting antibiotics immediately prevents sepsis. And, he feels that, even if our residents do have something that's viral, that he's afraid that it could turn into pneumonia or something down the road, so he wants to get antibiotics on board anytime that anybody is sick. How would you deal with a physician with that mindset?
That's a very tough one. So is he open to, reading evidence or guidelines if you provide those?
I actually had a talk with him yesterday about doing things like waiting until cultures came back to start the correct antibiotic initially, things like that. He's just not really interested in hearing it.
So I think that there has to at least be an openness to sort of, receive new information that might change your thought process. He sounds, I run into, as we try to do interventions to help providers change their prescribing practices, I've seen the whole spectrum from people who are sort of, out there on the front line and really wanting to address stewardship aggressively and totally engage and want to learn everything that we have to say about, how to prevent unnecessary prescribing, all the way to the other end of the spectrum, which is what you're describing, which are people who just, they're, for lack of a better term, very set in their ways. And as Lori said, one of the main drivers of inappropriate prescribing is a habit. It's just what you do, it's what you've always done, it's what you're comfortable doing. And trying to get people to move who are sort of at that of that mindset is going to be very, very difficult. So, you said you're in a long-term care setting, is that right?
Yes, we are.
So, maybe some of what you could, I like your idea of trying to suggest, how about if we wait for the cultures, because this patient is under 24-hour surveillance, and if things start to look bad with monitoring, then we can jump on it. It's not like you're sending somebody out the door and you don't know what's going to happen. So I wonder if, the emphasis on the fact that these are patients who are monitored, 24/7, and the ability to watch for any deterioration is really pretty good. Whether you might be able to use that to your advantage.
I'll try playing that card.
Lori, I don't know if you have a suggestion.
Rita, I really liked your answer. It's funny because I've listened to some other lectures where the joke is that you just have to wait until they retire and then things will get better. But obviously, it's not, and you're trying to do the right thing. You are trying to do the right thing by your patients. One thing that we've been trying to do here is really better characterize the risk associated with antibiotic use, especially in older adults and patients in long-term care facilities. So, you know, that's the other angle you might want to take. I don't know if you've seen C. difficile at all in your facility or other adverse events associated with antibiotics. I think that may be another angle that you can take. You know, I wouldn't want to give my mother an antibiotic if she didn't need it, or my grandmother an antibiotic if she didn't need it in a facility, and have her suffer the consequences of a C. difficile infection. So that's another, I would say, I agree it's a very difficult thing to do, to change someone's mind or behavior if they've been doing this for decades, but my hope is there's some increasing awareness about the downsides and risks associated with antibiotic use.
Okay, thank you both for those thoughtful responses and all the responses to our questions. We do need to wrap up our event today. So we're interested in hearing from the participants what are your key takeaways from today's event. If you can take a minute and put those into chat, we're very interested in getting that feedback. And we want to leave the call in action, so hope that you are able to identify one communication strategy that you can use to avoid unnecessary antibiotic prescribing, and maybe identify a community partner that you can engage in your efforts. Also want to remind everyone to complete the post-event assessment when you exit the WebEx today. The assessment will automatically pop up on your screen, and this will help us guide content for our future national LAN events, and it also provides the link to the CE evaluation. And Rachel will put that link in the chat as well to our post-event assessment. So we'd like to give you the opportunity to send any topic ideas you have for future offerings through this venue. If you have any needs or ideas, please send them through chat or email us. Our email address is qincc@area-d as in dog, .hcqis.org. And we do ask you to save the date. So this is an annual event on antibiotic stewardship. We will have another antibiotic stewardship national LAN event next year on Wednesday, August 29th, 2018 at the same time, 3 to 4:30 Eastern. So save the date and go ahead and register for the call next year. We will provide the link in chat to register for that call as well. And then I just want to let everyone know, I know there was a lot of questions in chat, and I'm very grateful for the discussion. We will compile the questions that were answered into a document and provide those to everyone on the QIOprogram.org website. So visit that website for all of the resources for this call. We will be sure to post the links to the videos once they are available, and that's where the slides and Q&A will be. So upon closing, once again, to remind you, when you close the WebEx, you will see the post-event assessment. Please take a minute to complete that, and that's how you will access the CE assessment as well. And I just want to thank our speakers again, Dr. Lori Hicks with the CDC and Dr. Rita Mangione-Smith with the University of Washington Department of Pediatrics. Thank you so much. And of course, thank you everybody who joined the call today. Hope you have a great afternoon.